Residency in Miami's Children's Hospital, Miami, Florida. Fellowship at WashU School of Medicine and St. Louis Children's Hospital. Then she was a postdoctoral fellow in biomedical engineering at WashU. And then did her advanced fellowship in pediatric and adult congenital cardiac electrophysiology at Children's Hospital, Boston Harvard Medical School. And then it looks like you consulted a little from Medtronic along the way as well. Right now, though, she's the director of pediatric electrophysiology, professor of pediatric cardiology, a faculty fellow in entrepreneurship. The list goes on. She's also professor of biomedical engineering. I'm not going to go through the many NIH R1s. You may have known her from her work in congenital heart disease, also in not just management of congenital heart disease, but the treatment of congenital heart disease, and more recently in visualization of cardiac conditions, both the mapping of it and what I think we're going to hear a little bit about is visualization as well. So, Dr. Jennifer Silva, highly accomplished cardiac electrophysiology, medical arm of this duo. And then we have Dr. Jonathan Silva. I actually know John from graduate school, so we're not going to go how far back that actually was. We go last period of time. I've known him for a very long time, but he did his master's in Case Western. He did his PhD at WashU, and then skipped. You started Johns Hopkins way long ago as an undergraduate on the science. Right now, he's a professor of biomedical engineering at Washington University, St. Louis. He too has a long list of successful NIH R01 grants that I'm not going to go into. I know John particularly well from, he really has led the field in developing new insights and advancing the field of voltage-gated sodium channel electrophysiology and dynamics. So that's where I know him from. But both of them together, which I think what they're going to talk about, have founded multiple companies. They have multiple patents that they share and don't share, and they're just remarkably successful in everything they do. So that very long introduction abbreviated, I turn the floor over to you, John.
Thank you for that very kind introduction. And it's very exciting for us to come over here. Met a lot of you at conferences, and we certainly know of the work that comes out of this institution. Let's see if I'm pushing the right button. There we go. The university does ask us to give some disclosures. The biggest ones are the companies we founded, Centia and Xera, and Jen in particular will be talking to you about the conflicted parts of our work. Before I start, there's just a lot of collaborators and students, and I like to thank them before the talk, before I run out of time, and I can't talk about it anymore. In particular, Jonathan Moreno was an MD PhD fellow in the lab, and he contributed a lot of the work, especially the clinical connection that I'll talk about. Juan Diju and Zoltan Varga basically got the protocols working and set the foundation. And then Lena Dang is another MD PhD fellow who's working with us on some of the metabolism work we're doing, along with Dhruv Bhagavan and Lucas Lee. Put together a lot of the slides I'll show you. So this is where I'll start. This is if you've gone to a lot of arrhythmia talks, this first panel on the left is one that comes up a lot. It's the CAST study. It's the cardiac arrhythmia suppression trial that happened in 1989. And if you look at the x-axis, you get days after randomization. On the y-axis, you have survival. And the blue line is placebo, while the green line is the therapy. And this is upside down. This means that they hurt more people than they helped. And it wasn't like they were just guessing. These drugs were very effective in terminating arrhythmias in an acute setting. And so they imagined that if they gave patients these drugs for a chronic condition, that they would reduce arrhythmias. But it ended up being very detrimental to those patients. So around the same time that I met Steve Polzing and we were grad students, the Made It trial came out, and we were in biomedical engineering, and the graph looks a lot better. So on the left, you have probability of survival. compared to conventional drug therapy, which is the line on the bottom. And you can see that patients with implanted defibrillators did quite a bit better. And so the mantra, especially in the biomedical engineering department, was antiarrhythmic drugs bad, defibrillators and devices great. And so I was one day explaining this to my wife, who's a physician and an electrophysiologist. I was a little bit mansplaining, and she said, "That's not right. I prescribe antiarrhythmic drugs all the time. A lot of patients are on antiarrhythmic drugs, and a lot of them do really well on antiarrhythmic drugs." That was a bit of an epiphany, that at least for me, that there are antiarrhythmic drug therapies that are very effective. And in fact, most patients who have a defibrillator get antiarrhythmic drug therapy because you don't want it going off all the time. So from an engineering perspective, we were thinking, oh yeah, just shock the heart right out of it. From a patient perspective, you don't really want to get your heart shocked out of an arrhythmia every couple hours, which is a kick in the chest and is not a safe way to continue living. So this is in the field led to a problem from our perspective, in that there's really not a lot of antiarrhythmic drug research. If you talk to big drug companies, they don't want to invest in antiarrhythmic drugs. A lot of research directors have come out on their shields. In academia, there's also kind of this bias against it as well, where even though they're prescribed across the globe, it's like a $5 billion market. There's not as much research as there was in the 80s and 90s. So our question is there certainly are situations where these drugs are beneficial. Can we start to understand why they're beneficial for some patients and not beneficial for others? And so we started with a very well-defined monogenic pathology, which is called long QT syndrome type 3. The sodium channel is the target of class 1 drugs, which was also the subject of the CAST trial. And long QT syndrome is a genetic variant, usually, that causes a gain of function in the cardiac sodium channel. So cardiac sodium channel initiates the action potential. Oh, there's my laser. And so you get this fast upstroke. And then most of the channels in the normal heart will inactivate, and that will allow the cell to repolarize. If you have a gain of function mutation, not all the channels inactivate, and you get this persistent current. That flux of positive charge from the persistent current causes a depolarization of the action potential. So the action potential in the ventricle gets longer. And then on the ECG, this interval between the QRS and the T wave reflects the ventricular action potential duration. And this prolongation is termed long QT syndrome. So long QT syndrome type 3 is from variants that affect the cardiac sodium channel. So there's a drug called mexiletine that should work really well to treat long QT3. So mexiletine is a derivative of lidocaine. Lidocaine is actually a very effective local anesthetic, which you've probably gotten at the dentist. It's also a very effective antiarrhythmic. The reason you can use it as a local anesthetic is because it gets metabolized very quickly. So it's not going to cause a lot of other problems if you inject it by your tooth nerve, because it's going to get digested or metabolized very quickly by the liver. But as an antiarrhythmic, you don't really want that. So you can give it via IV in the clinic, or you can modify it so it doesn't get metabolized as quickly. And that's what the drug companies did with mexiletine. You can see that the structure is very similar, but hepatic metabolism is about 10% compared to lidocaine, which is 70%. The one interesting part of mexiletine, though, is that it can block this late current pretty substantially. And you're going kind of right to the source of the pathology. You have late current for the sodium channels, and then this drug directly blocks it. So it seems like it should be a really good therapy for long QT patients, right? They have extra late current. This drug blocks the late current. You're addressing the problem in a very straightforward way. But then again, we run into this issue where some patients do really well on the antiarrhythmic and others don't, even for a very well-defined pathology. So here we have a patient who responded quite well. They had a QTC of the corrected QT interval for heart rate of 480 milliseconds, and it went down to 420. You usually want below about 450. And so you can see this worked really well for this patient. And another patient who had a very prolonged QT interval of 600 milliseconds, and they got the same therapy and nothing changed. So before and after this drug therapy, they had the same corrected QT interval. And here's the summary data. On the right, where some patients responded really well, other patients didn't respond at all to the drug. So we have quite a bit of patient variability, which is kind of the situation in general for antiarrhythmic drug therapy. So our role, especially at this time in the lab, was to think about how the sodium channel might contribute to this variability. And we had developed a method that was first used in muscle channels, skeletal muscle channels at the University of Chicago. And we brought this to the cardiac sodium channel, where we put fluorescent molecules on different repeats of the cardiac sodium channel. And so you can see here that the sodium channel has 4 repeats. Each repeat has 2 domains, a voltage sensing domain and a pore domain. And we put a fluorescent molecule on the top of each of the voltage sensing domains for the 4 repeats. And what happens is that fluorescent molecule will change environment as that part of the protein moves, and we see a change in the fluorescence signal. So the environment changes, we see a change in fluorescence. So we can watch the molecule move at the same time that we're observing its function in terms of its ionic current. So these are the first recordings that Zoltan Varga got. And you can see, we can see the currents, we can see the fluorescence at the same time, and we can plot the change in fluorescence as we apply the voltage pulses to characterize the channel. So what Wandiju did was put mexiletine on there, which is the drug we're interested in. And she looked at these 4 domains to see how mexiletine might be affecting each of these domains. And you can see there's not really much to write home about for domain 1, domain 2, or domain 4. But in domain 3, we see a pretty big left shift. So what that means is we have to apply a much harder, much stronger potential to pull that part of the channel back down to the resting state when mexilatine's in there. So on the x-axis, we have the membrane potential that we're applying. On the y-axis, we have the normalized potential, or the change in fluorescence when we apply this pulse. And we can't actually pull that domain 3 voltage sensing domain back to the resting state, even if we apply a pulse of minus 180 millivolts. So what that tells us is mexilatine's getting in there, it's kind of jamming up the system. So even if we pull really hard, we can't get domain 3 back down, which is kind of interesting. So we have the part of the channel that the drug's interacting with. And then we started looking at these variants. And so this was very interesting. So first thing we looked at was how the drug blocked, and to see if that was similar to the clinical phenotype. And you can see here for the patient that didn't respond, they had this M1652R variant. We needed more drug to block the channel. For the patient that did respond, R1626P, we needed less drug to block the channel compared to wild type even. So something about R1626P is allowing the drug to block better, and something about M1652R is making it resistant to the drug. And then we saw this trend when we plotted the domain or the repeat 3 voltage sensor activation. So this is our fluorescent, where we saw a pattern that kind of mimicked the change in the drug effect, where the M1652R tended to be closed at more negative potentials, while R1626P tended to be more open. So we thought that was an interesting correlation, but it's only 2 variants. So what Wandi did is introduce all the variants that we had data for, or ECGs on, and she plotted the half potential that we needed to activate that repeat 3 voltage sensor domain. And she saw a very strong correlation, especially if we applied a Boltzmann curve, which kind of makes sense. There's limits to which our domain 3 activation can affect the drug block. And that's why the curve probably tails off on either end. But we saw a really nice pattern here, where it changes the effect of the variant on the domain 3 repeat was affecting how the drug blocked. And this was surprising because you can see most of the variants aren't close to the 3rd repeat. So your first thought would be like, oh, well, if a variant is really close to repeat 3, that's going to affect its activation. But the channel is very well connected. There's a lot of cooperativity. And so a lot of these repeat 4 variants are affecting how repeat 3 moves, and that's what's affecting the drug block. So we tried to go a little bit further and say, can we predict the QT change? So we had the QT change data for each of these variants from the Priori lab. And we wanted to say, okay, can we predict the change in QT interval? We also want to predict something called use-dependent block, but that got pretty complicated. So we created a partial least squared regression model. And this is a good model if there's a lot of collinearity between the variables that you're looking at. And we first did feature selection. So we thought of all the features that might predict whether the change in QT interval, and we kind of listed them out. We did feature selection to see which were the ones that were most important for the prediction, and we came up with two. One was the domain 3 activation or repeat 3 activation. The second one was the time constant of recovery from inactivation. So how quickly does the channel come back after it's inactivated? And there was a slow time constant, and that was also very predictive. And we got a really nice correlation when we used those two variables. So then we called the Priori lab and we said, we're ready to publish the paper. Let's send it to a really high impact journal. And they'll certainly publish it. And they came back to us and they said, how about we go find some new patients that you don't know what happened, and then you plug this into your model. And that was really kind of terrifying because we didn't know how it was going to do. So they went to the basement in Italy and pulled out data that they hadn't wanted to deal with before because it was on paper ECGs. And so they pulled out the paper ECGs and they sent us the variants and they said, why don't you make a prediction? And so we gave them the bounds of where the model said. And we were pretty good on 7 out of 8 that they sent us. We were off on 1, and they had a QT interval of 814, which is extremely prolonged, right? So if you think about 450 is normal, this is quite long as what you'd expect. So it's not that surprising that there's a different regime of behavior there. But for the ones that were normally prolonged, these are still dangerously prolonged. We did pretty well in predicting the outcome. Actually, I will tell you this. So one thing, so where do we go from here? One thing that we were interested in is creating a model of this activation. So Jonathan Moreno worked a bit on incorporating these aspects that we measured into a computational model. And one thing that came out was when the drug is effective, at least in the cell simulations, the voltage sensor or the domain 3 tends to be activated. So what we thought is, why don't we apply a biotin or attach a biotin to this sulfur that we've introduced in the domain 3 repeat and artificially pull it up. So let's see if maybe if not a variant does it, but we actually attach something there and we pull it up. Are we able to cause better drug block? And it turns out we were. So when here's the variant that allows us to attach a biotin. And when we put the biotin there, we're actually able to block the channel quite a bit better. And even for that variant that was resistant to the drug block, when we apply the biotin, we get better drug block. So right now, we actually have some funding to start to do a drug screen and maybe identify a small molecule that'll bind to the activated repeat 3 of the sodium channel and maybe improve therapy for a wider range of patients. Another thing that happened was, and this came from talking to Jen, is I said, okay, let's go and start predicting whether or not long QT3 patients will respond to mixolotine therapy. And it seemed pretty exciting, right? We could have a patient with a variant come in, and then we could say whether or not mixolotine would be really good therapy. And she said, well, that's really exciting, but I only see one of those patients every 2 years. And so you're gonna have to enroll almost every hospital in the world to get enough patients to really prove this out. And so that kind of left us a little stuck because we had this really cool way of predicting it. And Priori Lab probably has the most long QT3 patients, and we predicted for all of theirs. So what are we gonna do with this? And one question we had is maybe we can start looking at common variants. So can we start thinking about whether just any patient coming in, having variants that are widespread across the population, will that affect their response to the drug? So we've been using a new system that we bought called the Patch Finder. It's a robotic patch clamp, and it's much more efficient than poking cells individually. And we get tonic block, we can pulse the channel at different frequencies. You can see that increasing the frequency of pulsing increases the ability of the drug to block the channel. And this is a very efficient way to get data. So we can get a drug binding curve in an afternoon instead of 2 weeks of constantly poking cells and hoping that they survive through the protocol. And so we've looked at 2 variants. We've looked at a bunch of common variants. These were the 4 we started for: R34C, S1103Y, H558R, and S524Y. S1103Y is interesting. About 25% of Black patients will have the S1103Y variant. H558R is also present in about 25% of the population. You can see here for lidocaine, for tonic block, we see a pretty strong left shift. The IC50 for wild type is about 136 micromolar. For this H558R variant, it's about 75. We see an even stronger effect for the S1103Y variant, where we see a pretty strong left shift here with mexilotine. And the IC50 is about 57 compared to 150. So it seems like common variants might be having a pretty large effect. So we're collaborating with Jennifer and a couple of fellows at the hospital. And we have a clinical study when we're enrolling patients, we're getting their genetics, and we're testing their mexilotine response. At the same time, if they have one of the variants we're interested in, we've collected iPS cardiomyocytes. And they just grew this week. So I'm hoping in the next couple of weeks, we start getting data from patient cells that we converted into cardiomyocytes. And then at the same time, when we were thinking about designing the trial, it was a little scary because different patients are going to metabolize drug differently. So we felt like how a patient metabolized drug and whether they took the drug was going to be a confounding factor in trying to connect their genetics to their mexilotine response. So we actually collect blood and send it to mass spec and quantify the different concentrations of drug. This has kind of opened up a new direction for us where we're getting genetic data, and we're getting and specifically we're getting genetic data from the enzymes that metabolize the antiarrhythmic drugs. So we get variants in the CYP enzymes that are part of the P450 pathway. And we also get how the different concentrations of drugs. And so this is our first PCA analysis with about 70 patients, looking at variants and how close they are to the active site of the enzyme, and looking at different correlations between carvedilol concentration, amiodarone, and mexilotine. It's kind of interesting that amiodarone and mexilotine, especially carvedilol, tend to be on orthogonal axes here in this first PCA analysis. So this is something that we're very interested in. So I'll go quickly through this. Amiodarone, this is kind of our trend of mexilotine. Long QT3 affects very few patients. Mexilotine is also kind of a second-line therapy. So we want to move into a direction where more patients are being prescribed this drug. So amiodarone is prescribed quite a bit. It's probably the most commonly prescribed antiarrhythmic drug in the US, 3 million prescriptions annually. So while we're having trouble enrolling mexilotine patients, amiodarone patients are really, there's a lot of them in the hospital. And you can see that in some trials, it can actually be pretty effective as an antiarrhythmic drug. It also blocks a lot of currents. So as opposed to mexilotine, which was fairly straightforward and mostly blocks the sodium current, amiodarone tends to block all of the currents. So we're using our IPS model system. So we have IPS cells. We put these in the patch liner. We can measure K currents. We can measure sodium currents, and we can get the amiodarone block of the different components. And then we've been putting into a computational model. So we get the amiodarone interaction with specific channels in the iPSCs. Then we put it in an adult human ventricular cell computational model. And then we can do simulations. So this is a reentry simulation. In 2D, we simulate scar tissue here in the middle. You can see that we get, when we do rapid pacing, we get reentrant activity. And this is kind of simulating an arrhythmia in 2D. And you can get a lot of insight from these two-dimensional simulations. And when we do it with amiodarone, and we even do a 1 micromolar dose, we can stop, at least it doesn't come back through the middle. You can see a little bit more curling around, but the reentry through the scar tissue is prevented by the drug. So we think this is kind of an interesting way to measure drug interactions, and then start to think about, okay, maybe metabolism, maybe genetic variants are going to alter the ability of the drug to be effective. Along the same lines, we've also been starting to think about 3D models. We're collaborating with a group in Austria that makes these models, the Planck group, and then they have a company that's been helping us make the models called Numericor. And so we started these first simulations here where we can this is a patient heart. They introduce the scar into the model. And then you can see here that if we pace fast, we can start to get reentrant activity. And then with the amiodarone, that reentrant, that curling around is prevented. So in patient hearts, now we have 24 from a paper that they published. We can start to say, okay, if we change the different parameters of amiodarone, when is it effective and when is it not effective? So I'll end there. I kind of rushed a little bit through the amiodarone part, but this is kind of the big picture. We feel like if we can get genetic information, we can get drug metabolism information, we can understand scar geometry for an MRI, we could combine that with experimental data that tells us how the drug is exactly interacting with the channels, with the electrophysiology. You can put that all together, especially with computational models, to predict patient response. So I think I'll stop there. Should we do questions at the end? Or should we do a couple questions now?
Let's see them to the end, if that's okay.
Okay, absolutely.
Excellent. Thank you. Thank you for the kind introduction. Thank you for having us today. We look forward to spending the day. So, John, as you can now tell from the first half of this conversation, spent a lot of time talking about work at home and what our problems are that we have at work and at home, and how we can try to help each other fix each other's problems. So what we just saw was a lot of the biophysics and the precision medicine on a very molecular level. And we're now going to shift and go to whole heart. So I'd like to show you some technologies that we've been working on together. So what you heard about was just how we treat tachyarrhythmias or abnormal fast heart rhythms. And we have medications, which is a mainstay of how we treat them. And that's really what the lab is focused on. But we also do procedures or cardiac catheter ablations. And this is what I do clinically. So I spend a lot of time thinking about catheter ablation. So what is catheter ablation, in case you haven't had one or haven't had to see one? It's when we thread catheters through the large veins in your neck or legs. We thread them into the heart, and then we record the electrical signals off of these electrical poles, convert those into tracings, create these maps, these electroanatomic maps, which are maps of the patient's anatomy overlaying the electrical activity so that our brains can understand it a little bit easier, and then target to get rid of or ablate the abnormal electrical circuit using ablation catheters. And we usually use fluoroscopy, which is a pretty bad imaging modality, but it's the best we have. So this is what I spend my day doing. And as I think about an electrophysiology study, it's very scripted. It has certain parts, right? We have pre-procedural planning. We have the patient prep and anesthesia. We have vascular access. It's a critical part of doing a procedure. We have the diagnostic part of the study, the therapeutic part of the study, and then the post-ablation EP study. Back in 2015, we were introduced to the medical extended realities, so virtual, augmented, and mixed reality. And we thought that these were going to be enabling technologies that were going to allow us to improve the way we did catheter ablation. So I'm going to spend a little bit of time today talking about these two systems, which are both disclosures for us. Some of these are also places that we work as well, but the technology is not far enough along to really have a meaningful conversation about it yet. Okay, so vascular access. This is how we do vascular access in the lab. You have a patient, they're laying on a table, You take an ultrasound probe, you scan for the vessel you want to put a needle in, then you take a needle, you try to put it in the hole that you see on the ultrasound. Now, the trick is that it looks something like this in real life. So this is my partner. You can see that here's the ultrasound screen, but you can see he's not looking at it because he's looking at his hands. That's generally what you do when you do a procedure. You look at the area that you're working on. But the problem is that the information he needs isn't in front of him. The information is over his left-hand shoulder. This is important because you tend to move in the direction that your hands are looking. So we decided that we were going to try to create a system where we could put the ultrasound right in front of you, right in front of your face, and overlay the ultrasound right on top of the patient, and then integrate into that tool tracking so you could see where your tool was relative to the plane of the ultrasound. So we were basically targeting ultrasound-based interventions, in this case, vascular access. And we wanted to create something that was super portable, easy to use, comfortable for the physician to use, and had really good connectivity. So here is the alpha prototype of what we call a Mantis system. And we took an OEM probe, actually. Let's see if I can make the movies work. You press that blue button, and then the ultrasound will actually get displayed from the tip of the ultrasound probe. And if that's scanning a patient, all the better. And this is what alpha prototype looks like. So you line up your needle, you advance your needle to try to get the needle in that hole, or if we can actually make it bigger here, we see the needle's moving towards the hole. And once the needle is in the hole, your arrows converge and you now know you're in your target vessel. It's actually kind of a simple problem, right? So why was this a problem? It was a problem because I was watching fellows do this. I'm like, why is this so hard? Put the needle in the hole. But it's hard if you haven't done it for 15 years, which is how long I've been doing it. So we then took this alpha prototype system and we said, okay, let's set up some mannequins and see if this actually made people better, or was it just the use of ultrasound? The use of ultrasound for vascular access became pretty standard within the last 7 years or so. So we studied this in a bunch of fellows, junior attendings, mid-level attendings, and senior attendings. I would count as a senior attending. And we were measuring how long it took them to access the vessel, the number of times they tried, the number of needle repositions, and then we were measuring something called the quality of access. So was your access stick a good stick? What does that mean? You generally want to be in the center of the vessel. You want to come in at an angle between 30 and 45 degrees, and you don't want to be at the side. And what we saw with all comers is that there didn't appear to be a significant difference in time to access, number of attempts or repositions, but the quality of the access actually did seem to be better. And then we had, inadvertently, our mannequin came with a vascular variant where instead of the artery and vein being in the normal orientation, they were not. And all of a sudden, people were much better. They were faster, they had fewer access attempts and fewer needle repositions when using our system. They also, by the way, had better quality of access. Why is this important? Vascular variants are seen in 36% of patients. It's more common in children, little old ladies, and females in general. So our underrepresented patients that we're really trying to take good care of. We also then said, okay, how usable was the system? You saw it. That's what we would call like a real alpha prototype, right? Like literally there are parts that were maybe held together with duct tape. True. So was the headset comfortable? Yeah, people thought it was. They thought the system was easy to use too, 87%. But here's where I thought it got really interesting. People believed it could decrease failed vascular access attempts and unintentional puncture of adjacent anatomies, 83%. So people just thought having this technology was going to make them better. Usually when you think you're going to be better, secret, you're going to be better. And 73% believed it could help decrease adverse outcomes. So what is the status of this technology? I didn't update this. So this technology, now instead of being this, We are now moving to a wireless probe and integrating that tip tracking technology, and is going to be used in a larger user group. So we originally had, I believe, 35 in our initial user group. This is now going to go into an approximately 100 user group study at Walter Reed. And the reason is that the Department of Defense has very interesting and unusual needs that we can have a separate conversation about later, but they're trying to upskill people, right? And we believe this is a technology that can help upskill people. So how about the diagnostic and therapeutic portion of the EP study? This is really, this is what I love doing. So during EP studies, we create these things called electroanatomic maps, and I sort of explained those to you. We project these in two orthogonal views, and then we have to mentally recreate what those look like. But instead, what we said is, what if we just take this data and we put it through our engine and then create a real-time 3D hologram of the patient's anatomy with their electroanatomic data, and then the real-time catheter locations. Could having this improved visualization, connectivity, and then, oh yes, by the way, control, so the physicians can control this however they want, would it make them better? So this is what version 1 of the system looked like, just to show you what the interface is. So version 1, you put on the headset whenever you want. Generally, people put it on up front, but then you see this open white circle. This is like your mouse. This follows your head around the room. It's like you can take your model, lock it into place. Once you've locked it into place, it's like a permanent object in the room. You can look around the corner at it. It's not going to move. Once it's anchored, you can then start doing things to it. So you have a clipping plane, which is kind of an interesting view because you can take an endocardial view of what you're doing. The clipping plane, we tell people, is your nose. It's very intuitive. You could create joined shared sessions. So if you're teaching fellows and you want them to go to a certain place, you can create a session where you're actually telling them, hey, go here. This is where I want you to ablate. You can also rotate the model in any view you want. Why is this important? Currently, the way it works is that another person has to do that for me. I have to use my words to tell them how I want to do that. Now I can just do that myself. We have the ability to use preset views, the ability to make it a really big model and then stand inside of it. That's always fun. And the ability to change the opacity. This is important because the lighting conditions in the room are constantly changing. So you want to be able to see your hologram. So we took version 1 into the cardiac augmented reality study, or the CARE study, and we had 3 hypotheses. The first was that holographic imaging would improve the physician's ability to point navigate and accurately do that. The second was that the system would be informative, comfortable, and easy to use. And the third was that it would reduce interactions between physician and people in the lab, particularly the person running the mapping system. So we were looking at accuracy, usability, and workflow. So what we found when we looked at accuracy is that people were much more accurate when using 3 dimensions. That's not surprising than when using the current electroanatomic mapping system. This difference, as it turns out, is going to be clinically relevant. You want to be as accurate as you can be when you're actually laying down lesions in people's hearts. The usability, it was really very comfortable to use. People used all the tools. Interestingly, easier to interpret than standard of care, 93%. And my personal favorite, 87%, felt like they learned something new about the anatomy. Earlier this week, I was just out at Beth Israel watching them do cases. And this is what they kept calling in to tell me. They're like, hey, do you see that? I never saw that before. Which is simultaneously exciting and concerning, right? Because we've been doing ablations for 20 years this way, at least. And then the number of interactions. And yes, the number of interactions do go down during certain points of the procedure, but not during all parts of the procedure. So then we did a separate sub-analysis, a case control study, where we looked at the patients who underwent the CARE trial and a time consistent cohort in a 2-to-1 matched ratio to see if we were altering the study duration or fluoroscopy exposure. Note, this is the first 16 patients who ever had this technology used. And what we found was there was no difference in case duration And actually no statistical difference in fluoroscopy exposure, even though it looks like there might be something to study here. I think that these data are important, particularly with brand new technologies, because if you're at least no different than standard of care, chances are you're actually on something. So version 2, which was FDA cleared this summer, is actually now in a study in Boston, and that's for the intraprocedural assessment and in a 3D image guided modality. It's a mouthful, or the paradigm study. We started enrolling at Mass General in May and now have a second site up at Beth Israel. We will have 8 users, about 30 to 40 users per study subjects per user. And the primary endpoint of this is, once again, navigational accuracy, because people simply couldn't believe that they were more accurate, that there's more accuracy to be had. So we're excited to have these data out, and I anticipate that we will have, well, an interim analysis shortly, and there's some noise to actually close the study early because the users now believe so strongly that they are more accurate that they actually worry that this is unethical to continue the study. Interesting problem. So this is what version 2 looks like. The headset is smaller. This is an AFib ablation over at Mass General. And you can see he's got his hologram and he's directing his catheter based on where he's trying to build out more geometry on his map. Nope. Okay. So the future of the EP lab. The EP lab is not that different than any other minimally invasive space. And I think that the future of all these labs is actually pretty much the same. This comes out of an interventional cardiology manuscript looking at the future of just regular cardiac catheterization. And what they said was that there are 4 things that they think are going to be the future. The first is having an augmented reality system. Just kidding, clicker's not working anymore. Okay. I agree. I think that the future is in augmented reality systems. The second is in having voice-assisted control of systems. Super interesting question. And John will remember, once upon a time, we had a system that did have voice control. And we took it on the roadshow around the world. And I promptly went off to Germany to go hang out in a German lab for 2 weeks. And it didn't work. And why was that? Probably because the natural language processing wasn't up to speed yet. 2, there's a very thick accent when Germans speak in English. They couldn't use it. In fact, it was so unusable that they said, can you take this out for us? And so we did. We actually stripped it out. I do think it's probably 10 years on the horizon, but it wasn't quite ready yet. It was a technology ahead of its time. So part of this is about meeting the needs and the technology at the right time. Third, clinical decision support. Yes, everybody's talking about AI. Yes, we think that there are ways to build that into the system that can actually make the physician better. And then lastly, the robotics. Everybody wants to talk about robots. Yes, do I think robots will help us do our job? Absolutely. The problem is that right now, all the robotic systems are going to AR interfaces. So they actually now need us in order to make robots work better. So who and where are developing mixed reality specifically for electrophysiology? We've got the group out in Poland that was working on using CT scans for anatomy prior to AFib ablation. We have the group out in Haifa that's using ultrasound predominantly as their imaging modality prior to intervention. We have the group in Boston that was using high-res MRI to visualize scar prior to VT ablation. We have a group out in San Francisco also using ultrasound to just work on left atrial appendage isolation, which is a separate thing that we do in patients with atrial fibrillation because it's a place where clots can form and you can get stroke. As it turns out, this technology doesn't seem to be working in this particular use case. And then lastly, our group in St. Louis, which is looking at mixed reality for the entire procedure. So I think the technologies are moving the practice of precision medicine in a forward direction. And I think it's happening at all the scales, right? It's happening both at the level of your ion channels and your genetics. It's also happening at the level of your whole heart. And it's going to have massive impact on patient care. I think that there are really big changes coming specifically to cardiac ablation for our patients with arrhythmias. And I think it's going to be very tangible. I think it's certainly going to be within the time frame of my career. Early data is very promising, but there's still a lot more to learn. These technologies with smart user interface and user experience development and clinical decision support with robotics will have a synergistic impact on minimally invasive procedures. We have to critically assess how these technologies can or cannot be translated into niche populations, like for me, pediatric and congenital populations. So our role is to really remain curious, ask questions, and stay engaged. I will end by my prediction that the practice of electrophysiology is going to be radically different in the next several years. And I actually, for one, am really looking forward to it. I will close with more acknowledgements because we really are very lucky to have all of these people who support us and allow us to do these things. And remind you. So, and John knows this because obviously he knows my dad pretty well. My dad, when I was 9 years old, brought home one of the first home PCs and said, you must learn how to code this because this is going to matter. It is going to change the world. He was right? So we were that generation that grew up and all of a sudden had internet one day. I remember that too. This generation is growing up differently. They're growing up with headsets and phones with massive computational power in their back pocket. And I think that's going to change their expectation of what technology should look like in whatever field they practice, even medicine. Thank you.
Great, so we have some time for questions. Yeah, just getting delivered.
Great talk, and thank both of you. I have to run off the meeting, but I want to make sure I get this in. Question for both of you, quick one. My experience with laboratory animals, I'm no surgeon, cannulating small vessels and things, is the haptic feedback is such an important part. I shouldn't admit this to anybody, but we used to cannulate these tiny vessels in the brain of animals and moving around curves. And I got to the point where I could almost close my eyes with the secting scope and sort of feel my, anyway, my point being, is there, other than the visual cues that are so important, is that built into the system as well?
It's interesting. So currently it's not. So there have been a lot of recent studies looking at the role of haptics in training and medical training in VR and AR. And the data has been very mixed towards leaning away from haptics as being an important feature. So right now we do not have haptics built in. It is certainly a hot topic of controversy, right? I mean, as controversial as it can be, right? On this, but right now we do not have haptic feedback built into the system.
And if I just ask you quickly on the VTAC and the odor site, what I may have missed it. What was the underlying pathology giving rise to VTAC? Was that from different kinds of patients, but myopathy?
Different scars. So we're starting by just kind of looking at the subacute phase. So after the scar has formed, but it hasn't been there for very long.
But from an ischemic event,
Yeah. And then that creates the scar.
Okay.
And then, so the question is how do the different variables of the drug interacting with different scars, right? So you imagine if there's a lot of narrow pathways, which is what they try and ablate when they do a procedure, maybe amyloid is helping with that because it's not letting the wave travel through these narrow isthmuses. But maybe there's other scars where it's going to be less effective. And there's just so many variables with this drug. We felt like a computational model could really help us with that aspect. Yeah.
I'm going to take the liberty of being a question for kind of both of you, starting with John. So you come up with a computational model that says X concentration of silicine based on your genetic background recommends X number of nanomoles per kilogram. And then we take it to the physician who says, all right, a computational model says X. How do you, both of you from your joint perspectives, how do you expect a physician to interact with it? And how do you actually expect to receive the information before it's going to change your practice?
I guess I would be nervous to say X concentration for this patient. I think what I would tell Jen is this patient will probably do well. with mixilotine, and my sense is that the current clinical practice is you try a drug and see if it works, and if it doesn't, you give another one. So this at least isn't a coin flip. We're saying, you know, based on what we see, that this is probably a good mixilotine candidate, or if we see the opposite, we can say this patient probably won't respond to mixilotine. So if you try it and you don't see a response, we know why.
So before you answer then, Jen, the follow-up to that is, as a physician, if you're going to prescribe a dose and then before you completely throw out the drug, you're going to start at some dose and try to adjust it right for efficacy. Is it going to, do you feel like we're at the stage where it really is going to change what you're going to prescribe first? Or do you think it just, yeah, how does it change your set point? All right, John's a smart guy. I know him.
Yeah.
For most things, you know.
Yeah. So I think it depends where on the adoption curve you fall, right? So I actually think that these things are actually pretty simple. So you have 96% of the population that'll use it if you can have some early adopters bear it out. So I think what you need to have are those super early, you know, bleeding edge kind of adopters. Now, finding those people can be I think that's quite frankly, I think that's half of the trick. I think half the time I spend talking to people, I'm trying to figure out, you know, because everybody says, oh, I'm an innovator. That's like the new word, right? Everybody is a clinician innovator. And I'm like, okay, great. So that's cool. And most clinician innovators are still in the 96%. So finding the people that would be willing. So how would me personally, and I know where I fall on the adoption curve, and you know where I fall on the adoption curve, I would probably take that information and say, okay, I'm going to start higher than what you've given me. I'm going to make sure I can achieve a reasonable clinical effect, and then I'm going to try to come down and see how close I get to where you are. Now, I do that in conjunction with my patients. So I will say that I'm really fortunate. My patients are, so I do pediatrics, which means you have to talk to the patient and the parents, right? So you have two sets of phenotypes that you're dealing with. They are generally very open to this if you explain to them the process. The problem is that you have to explain the process, which means you have to yourself understand it, number one. And number two, be open about what failure looks like, right? So if you can do that in a very authentic way, my patients come in and they say, okay, so what are we studying now? What are you working on? Like, what study can you put my kid in? And I'm like, no studies right now. Cool your jets, right? Like, we're not doing anything right now. Or, yeah, I have this study here that maybe your kid can go into, or I have this study here that you can go into. But that comes from years of building that relationship so that when they go into a study, hopefully everything works. But if it doesn't, they know that it was, you know, and I have families that will say, I don't want my kid to be a guinea pig. Yes, agreed. I also don't want your child to be a guinea pig, but we are trying to push the science forward so that we can take the best care, not just of your child, but for all the other kids that are going to come. So that relationship building is really critical. And you have to do like the legwork on it in order to bring all these other things behind it. So when we first did that first care study, we said, oh, it's going to take a couple months. It took us 2.5 weeks to complete enrollment because every patient that came through was like, hologram, I'm in. And I was like, no. Let me explain to you what's going to happen. They're like, no, stop talking. We're in. Like every single one of them, because they knew me and they knew that I wasn't going to do anything that would really put them in any meaningful risk in any way. And so this is part of that trick, right? When you're working in the space of translational science, somebody's got to put in that time. And so what we've now done is we've expanded out our team so that we have not just 3 attendings, but we have a PA and we have a nurse that spend 9/10 of their time talking to patients. That's all they do. That they just have to talk to them about everything, anything under the sun, and build that relationship so that when studies like this come through, the amiodarone study will be very easy for us.
So it's really good. I like the personalization of the visualization, kind of better deliver the therapies. I can see how that has high value. Have you thought about whether or not the other Dr. Silva's have can help inform the strategy. So like ablations like fail, like the repeat ablation for up to like 50%. So obviously, if you can improve delivery, you improve there. But everyone has their own theories about given the pathology of, you know, if it's substrate modification or, you know, PVI or, you know, you're going after hotspots and trying to tackle activators. Can we introduce on the genetic side of it to try to better understand what the appropriate strategy would be? Or is it the tried and true, like get in there and see what you see and then just go after that?
So I'll start. I think atrial fibrillation has to be put in a separate bucket. I don't think that you can bin it with the rest of the arrhythmias, even other anatomic arrhythmias. I do think that we can probably do predictions for just about any other arrhythmia, mostly because we mechanistically understand most other arrhythmias. I don't mechanistically understand AFib. It makes my head hurt. So I have a hard time, and you know, we look at a lot of technologies, obviously. Have a hard time when people say, give me your data. I'm going to put it through my secret black box and give you a lesion set. Now we did this, right? We can make people do that lesion set better, but I'm not sure. I don't know. What do you think?
Yeah, I'm kind of curious about this metabolism data. Like, I think one thing that we're seeing, and I agree with the AFib 100%. What we're seeing is that people are taking different drugs depending on how they're metabolizing them, especially with amiodarone. And so I'm really curious if, and you know, when you're a scientist, you buy the drug off of Sigma and you put it in. You don't actually go spend $20,000 and buy the metabolites, which is crazy, right? Because you can buy amiodarone for like $100. So of course your PI is going to be like, do that one. But yeah, when you get all these different metabolites, you have to get someone to synthesize them, and unless you can do it yourself, it's very expensive. But then when we put it in on the cells, it acts totally differently. So I'm really curious, especially looking at these CYP pathways, can we start to understand at least what drug the patients are taking? So I don't know if we'll get so far as to say, do this or do that, but at least we might be able to tell the physicians, this patient's taking a different drug than you think they are.
Dr. LeConte.
I'll try to be quick, and cardiac people forgive me for hijacking this. I'm going to ask you a more meta question. So I work really closely with Steve on the medical school side. And so we're always talking about how can we sort of further or enhance conversations between basic scientists and clinical researchers. And I'm distilling it down to basic and clinical. So I'm wondering whether, I mean, this clearly works really well. There's a lot of back and forth and iteration and short of recommending marriage. Have you thought much about how to replicate this interaction and this sort of fast-paced, fast-fail model of moving basic into clinical?
I feel like I've talked this a lot. I've gotten some pushback from our department a little bit. I feel like it's really important for scientists to talk to physicians who are doing clinic 80% or more of the time, because we tend to be like, oh yeah, we talk to clinicians, but they're physicians who are mostly in the lab, and the physicians who are going to tell you that's not important. Like, I don't see that kind of patient very often, are the ones that see patients all the time. So I kind of feel like you have an advantage here, because you do have a lot of physicians who see patients all the time here. And I kind of feel like that interaction saying, this is what we're working on, how would this affect your practice? And I'm surprised how often the response is not very much, but if you do this one thing, that would be really cool.
Yeah, so I'm going to add to that. I think there's a couple things. So I agree with that. But two, I think you have to have dedicated time to it, right? So we do have a lab meeting, right? Where the clinical people get on, study coordinators get on, you get on, I mean, the residents, whoever can get on gets on. That's tricky and it's hard. And everybody's, you know, nobody has time for it, but you simultaneously have to make time for it. And part of it is to try to, I think it does matter if you can incentivize some of it. And that becomes a different conversation, and people who think about this have now left the room. So now we can say, but I do think that you need to incentivize both parties to come to the table. The other thing that I think is really what I learned is that I poorly articulate my problem. I think I know what my problem is, and I will come home and say, this is my problem, solve for this. And he's like, I don't think that's actually your problem. And then I go back and I'm looking and I'm like, oh, maybe that's not my problem. Maybe that's just what I see at first blush as my problem. And so I encourage other clinicians who are constantly saying, well, I know my problem and I know what they need to do. They just need to do it. The phrase, I just need to find an engineer to do it. I'm like, that's actually not how this works. In fact, that's the opposite of how this works, right? I didn't know how to engineer these things. I just knew that I wanted something kind of like this. And then we started iterating very, very quickly. Oh, I like this. Oh, I don't like this. Why don't I like this? I don't know. I can't verbalize it, or I can verbalize why I don't like this. So I think we also, clinicians have to get better at.
I tried to put
Filling it
virtual
out.
hands in the hologram, and it was super cool. It was like this neural network predicted hand thing, and she's like, my hands are on the catheter.
We're a little over time. If you want to ask questions after, I think you're going to meet with the students, and I saw William had his hand up, so if you want to save your, maybe it's just stretching. I was just stretching. You'll meet with students after, but thank you all. Leslie, don't leave. I want to check real quick. But thank you, Dr. Silva.